Jonathan. And many thanks to Assam and Kara and the whole team for such a well-run meeting. It's a real pleasure. I had met Bob before through the IRATs, but really in 2010, under the vision of Larry Clark, the Quantitative Imaging Network was formed. And that's where I really started to get to know Bob better. I'm sure you can't read it, but I found the old program, and there was Jim Mounts from Pittsburgh, John Boatti from Iowa, who's still charging on with this work, Bob Gillies, Daniel Rubin from Stanford, who brought in Sandy Nappel, myself, Tommy Ankloff, and we had our first meeting, and we all shared our talk. So this was Bob's cover slide, and we had it had Bob, the two Bobs, and Andre Decker there. And ironically, the topic was nothing at all what we were doing, but it's now what I'm actually doing right now in our own research, as Matt knows. Bob was a consultant on our SPORE grant on lung cancer, which is still going. And in April, we had an advisory meeting. He showed up on Zoom with oxygen tanks and all, and was a real critical thinker through guiding us through that. It's pretty remarkable. And then at some point after that, this was I think Hazel might have shown this yesterday, but when Bob got the gold medal at the WMIC, we took him out for dinner in Seattle, and that was happy days. Then because of this, one of my best volunteer gigs ever was being the AAPM liaison to the RSNA. Basically, the only thing I had to do was organize these symposia with the plenary sessions. And so I always tried to get a leading scientist and a leading clinician scientist to talk about the same thing. I thought, okay, this radiomics might have some legs. So I asked Bob and Hedy Hrisak to talk back to back on the basic science and clinical, but of course they did both as well too. That was in 2014. I was standing room only, and then that led, because of Hedy's initiative, to this. Sorry, here's one of the slides from the talk, because this will come up. I remember when he showed this, and I go, oh, it can't be that hard. He was saying just how difficult the curation was, and this is for only 285 patients. They lost half the data to curation, and it took 3 hours, 3 person hours per patient. Anyways, that led to this article a couple of years ago, and it was really Hedy who drove it, but Bob who provided the title, as you know. And one of the sections in here is called Building Databases, Numbers are King, Quality is Queen. Is where the title of my talk came from. And by no means was the intent that king is, higher in rank than queen. They both have regal justifications and roles, and sometimes the queen's in charge and sometimes the king's in charge. And thanks to Mary Ellen for pointing that out as the PI of the Midrick grant. But one of the things in there, one of the comments was, well, you have to have sufficient data. So numbers matter, but quality matters too, as Dr. Dilling's going to talk about after this. A couple things pulled from that paper, building off of Bob's presentation, was, it's really time consuming. I'll come back to that. And a big challenge is, no surprise to us now, was sharing data. Two approaches, as is well known now, is large central repositories or federated approaches. Buried in there, which I hadn't appreciated at the time, was the use of Radlex type annotations to help with making data more accessible and mineable. In other words, fair. Now, fast forward to just a couple years ago, and this is about now talking about COVID, not cancer. I'm sure most of you have seen these papers or things like it, but there was just an explosion of AI research to help deal or find some help with the whole COVID pandemic. And there was some really good, thoughtful articles. These are just two that I have, but there's many more, including some commission reports, and you name it. Many reasons, some of them due to poor scientific design, poor communication, but one of them is the lack of quality data. And there was even this one term coined in a paper called Frankenstein data sets, where well-meaning individuals would pull together different data sets, but they'd have duplicates of the same cohorts embedded within it. And without knowing it, that people would try to train on it. But of course, you could see that that would lead to problems. And so essentially, it's a lack of curation. It was one of the things. There's other reasons, of course, poor scientific planning, but the data sets was one of those. As Mary Ellen mentioned yesterday, as part of that response to COVID, NIBIB funded MIDRIC, which you can't read, but it stands for the Medical Imaging and Data Resource Center. And Mary Ellen and I have plenty of little cards to hand out if you're interested. It's a big program. NIBIB has funded it for, we're in our third year now. And the basic idea is the top left is we have many imaging centers primarily contributing CT and X-ray data, all DICOM format, which is essential for all of this. And then it goes into MIDRIC where it's curated, annotated, sequestered. And then one of the main goals is to make this available as a curated data source with sequestration for people developing algorithms and to provide methods for testing. The numbers below are way out of date, actually. I just checked a couple of days ago. We now actually have 105,000 studies or exams available publicly. It's gone. We're expecting to hit 150 fairly soon. So the curation here leads to cohort selection and also just general validity of the results. Just to illustrate the need for curation, the left one is on the image side, and we just pulled a random set of studies that were labeled as chest X-rays, and you can see the wide variety. If you look a little closer in the middle, you'll see a knee, there's a pair of knees. This was something that's labeled as, so if you're not looking at the images and you just grab a bunch of things and say chest X-rays, it'd be interesting to see what the algorithms would do trained on a knee image or being tested on a knee image. The other part that I'm going to focus on more is the DICOM. DICOM is a wonderful standard. It's far ahead of most other forms of electronic health records, and it's closer to FAIR, but it still has issues, one of which is the free text fields. So on the right, we looked at 5,500 abdominal CT scans of patients with COVID. And we just looked to see what the study description said. And you can't quite see the numbers, but each row is a different study description with the total number and percentage, and it's a very long-tailed distribution. In this case, there were over 350 different study descriptions, all basically describing the same thing. So it makes it it's a challenge for making things mineable. So what did we do? So there's two aspects. One is the images themselves. I won't go into that here. The second part of these free text fields, which we realized we had to address pretty quickly. RADLEX was an interest, was a place to start. However, RADLEX has 75,000 terms. And so this is not something that would necessarily help somebody who's just kind of scrolling through a list. However, we all agreed that we needed to use a standardized lexicon. We don't want to just create yet another, for lack of a better word, an amateur standard, not maintained by a professional standards organization. And a key thing is balancing detail versus generalizability. One of the things that I discovered, many of you may know about this, but I wasn't aware of it until a couple of years ago, was the LOINC, Logical Observation Identifiers, Names and Codes, which is started in 1994 by the Reagan Strife. And it's part of the Uniform Measurement Language System and other standards, and it's actively maintained. And separately, the RSNA had taken the RADLEX terminology and started to build something called the RADLEX Playbook, which is like a common centralized description of radiology procedures. And so RADLEX and the RSNA, RADLEX effort, and Reagan Strife merged. They realized they were both working on this, so they merged their efforts about 2013. And there is something called the LOINC RSNA Radiology Playbook, and it's included in the LOINC distribution, actively maintained. RADLEX, as a result, is no longer being maintained, but the LOINC version is. And there's some commonalities. So in DICOM, we would have something like the study description, which was variable, as I showed earlier. LOINC has a long common name, which is pretty close to the same thing, and it's guaranteed to be unique. It's an algorithmically determined name built up based on the other components. And there's other terms such as modality or method, region. So it provided a systematic and a very controlled mechanism for defining terminology. And so this is what we've implemented now within the MIDRC, this one small part, the data quality and harmonization group. So we take the DICOM metadata, which is on the top left, and I don't think you could read the column headers, but the one on the far left is modality, then study description, then the number of counts. And then over in the LOINC code section, we have a LOINC code, which is just a number. And it has a unique LOINC long common name, and then a method and a chest. So it's this is my second to last slide. At the time of evaluation, we've done it again. These are old results, but we had 62,000 exams, and we were able to map 95% of the study descriptions to only 76 terms. So really making a much more addressable term. And then there's other problems because, data sometimes, centers will do as they will. So we've worked out this to provide a method, and it's interesting to look back that a lot of this was really kind of predicted by Bob and Hetty in this original paper, which at the time I remember thinking, I wonder what they're getting at. Now I see. I just want to finish up with this one last slide, thinking again about Bob. There's a study a prayer from the Baha'i faith that's a part that's always stuck with me. And in part it goes be lions roaring in the forests of knowledge and wisdom, and whales swimming in the oceans of life. And I think it applies to Bob, perfectly. And it's the advice he gave all of us as well too. And I thank him for that. And I thank you for your attention.
Thank you, Paul.